Yeah, sure. So the dynamic trial was a multi-center randomized phase 2 study really designed to test the question if an adjuvant chemotherapy decision based on a ctDNA result could reduce the use of chemotherapy without compromising the recurrence outcome in stage 2 colon cancer. So about 455 patients were randomized in a 2-to-1 fashion to a ctDNA-guided management or standard management. So in the ctDNA-guided arm, post-op ctDNA was assessed at 4 or 7 weeks using a tumor-informed personalized NGS-based assay called SafeSeq. And then those with a positive result receive adjuvant chemotherapy, while negative results were observed. In the standard management, clinician's decision on chemotherapy is relying on clinical pathological criteria, which is our current standard practice. Taking into account of tumor stage T4, poorly differentiation, lymphovascular invasion, for example, for the chemo decisions. So in terms of outcome, what we found was the ctDNA-guided approach indeed almost halved the use of adjuvant chemotherapy from 28% in the standard management arm down to 15% using ctDNA to guide treatment. And at the 5-year follow-up update, we found that recurrence-free survival was really non-inferior with ctDNA guidance compared to standard management. So it was a positive trial from that sense. And overall survival was really comparable between the two group of patients. And importantly, among the ctDNA positive patient, we saw a high rate of ctDNA clearance after chemotherapy, indicating treatment efficacy. In general, I don't think there was any unexpected finding with the longer term recurrence of survival. I think what is very notable is the 5-year oral survival was very good, 93%, and cancer-specific survival was even better at 97% across both arms, largely because more than half of the death in stage 2 colon cancer were actually not attributable to colorectal cancer, but from death from other causes. We also found a very high ctDNA clearance rate, which was notable but sort of anticipated, reinforcing chemotherapy's role in eradicating minimal residual disease. Um, Another key observation was that a high post-op ctDNA level strongly predicted for worse recurrence-free survival, which, while not surprising, underscore ctDNA's prognostic precision in predicting recurrence outcome. And while there's a slightly delayed chemotherapy start time in the ctDNA guided arm by 11.9 weeks compared to the standard management arm, that did not adversely impact on patient's outcome. I think the dynamic trial solidifies ctDNA as a highly prognostic biomarker in stage 2 colon cancer, really stemming from our previous observational study, and confirms that post-op ctDNA positivity does identify a patient with MRD and a high recurrence risk if untreated, justifying chemotherapy, while negative result reliably predicts low risk and allowing for de-escalation. The trial shift practice by providing, I think, first-time evidence from a randomized setting that a ctDNA guided approach can reduce chemotherapy use without compromising patients' outcome. And it challenges traditional clinical pathological risk stratification, which often overtreats a significant number of patients. I think in clinical trials, ctDNA will be pivotal for, I think, firstly, stratification to enrich trials with very high risk patients, such as your ctDNA positive patient across various stages, to test novel therapy or escalation strategy. And on the other hand, the ctDNA negative patient, we could use it to evaluate because they have low risk chemotherapy omission or shortening or a de-escalation strategy, particularly relevant for stage 3 colon cancer, where currently all patients are exposed to pretty intense chemotherapy and the duration is uncertain, 3 versus 6 months. The other utility in dynamic in the trial setting would be for dynamic monitoring of real-time treatment efficacy using serial ctDNA-Guided treatment adjustment, or even looking forward in the future if neoadjuvant treatment become a, a treatment option to assess neoadjuvant efficacy in a locally advanced disease setting. We could also use ctDNA clearance and leveraging that as a potential surrogate endpoint as a proxy for recurrence-free survival to accelerate trial design. I think in real world practice, as evidenced by dynamic trial, we certainly could use ctDNA further be more precise in how we risk stratify a patient to tailor treatment, reducing over treatment. I think is probably the most relevant use at the moment. In terms of escalating treatment to improve patient outcome, we probably do need a better treatment than what we have currently in use in standard practice, just with a couple of chemotherapy agents. In the future, I think, pending trial data confirmation, we could potentially use ctDNA as a surveillance tool. Firstly, potentially to shorten surveillance duration. Currently, it's 5 years. We may be able to shorten to 2 or 3 years. Or instead of using CT scan regularly, we can just use ctDNA. Obviously, we need to await clinical trial data to incorporate them into standard practice. We did not, I think, have sufficient power to do in-depth subgroup analysis. There doesn't seem to be a particular subgroup that benefited or less or more from this approach. I do have to caution that deficient mismatch repair tumors are a particular group of patients that is quite prevalent in stage 2, and now potentially there's immunotherapy option in the adjuvant setting. We'll wait for the atomic data to be presented, hopefully at ASCO this year, we'll see. That may be a subgroup of patient where ctDNA guide using chemotherapy may be less relevant. Again, I think that the numbers are quite small in our study to make any meaningful interpretation of subgroup analysis. I think the first next step will be randomized phase 3 validation in larger trials, such as a couple of trials in European countries that can confirm ctDNA predictive for utility and to establish it as a standard care biomarker. There are, I think, some concern about potential false negative results with ctDNA. So particularly with low shedding tumors, so they're likely going to be, I think, assay refinement, as we know now, technologies have improved significantly, and no doubt that with assay refinement we'll reduce some of the false negative rate. Looking into the future to investigate more optimal chemotherapy regimen, we still don't know whether ctDNA positive patient benefit equally or more from doublet versus single agent chemotherapy, and also the duration of treatment remains to be seen, whether we need 6 months of treatment or whether 3 months is sufficient to clear the ctDNA. And to expand really, I think, beyond stage 2, looking at stage 3 colon cancer, looking at resected stage 4 colon cancer would be other future applications.